Hello, my name is Dr. Ostaszkiewicz. I'm a registered nurse and a director of the Aged Care Research Program at the National Ageing Research Institute in Melbourne, Australia. My colleagues and I at the Institute would like to thank the International Continence Society for this opportunity to present our work. I begin today by acknowledging the traditional custodians of the land on which we meet here in Australia, and to pay my respects to the elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people here today. The study that I'm about to present to you was commissioned and funded by the Continence Foundation of Australia, and I was supported to attend this meeting by my institution. The aims of the study were to co-design and pilot test a best practice model of continence care and knowledge translation resources for use in Australian residential aged care homes. It was quite a complex study characterised by an iterative process of collecting and synthesising evidence from multiple sources, including qualitative and quantitative evidence. The first activity was a scoping review about the prevalence of bladder and bowel symptoms in residential aged care homes, risk factors, impact, and the effects of interventions. And we also reviewed frameworks and policy documents. The second activity was a survey of residential aged care stakeholders to identify the relative importance of several factors related to continence care in residential aged care homes. Thereafter, qualitative interviews with the subset were undertaken to further explore their expectations and beliefs about continence care in this setting. Thereafter, 2 co-designed workshops were convened with another group of residential aged care stakeholders, again to explore their expectations and to invite their input into the co-design of the model. Data from each of these sources was synthesised to draft the model and accompanying resources. And thereafter, the model and resources were piloted in 6 residential aged care homes with reference to nurses and personal care attendants. And the final activity was to validate it through qualitative interviews with aged care residents. Consistent with co-design principles, we had a project advisory group who advised us on each stage of the project, and we consulted with experts to advise on gaps and inconsistencies in evidence. And here are the findings from each of those activities. So the review of literature identified multiple papers, over almost 2,000 and over 500 guidelines. And the findings from each review paper were then extracted, categorised and translated into several evidence-based statements and recommendations that underpin the evidence base for the model. And each evidence-based statement was mapped to 1 or more standards for care in our Australian residential aged care homes. In the online survey, we asked residential aged care stakeholders to rate the factors in this table in terms of their importance to continence care, from not at all important to very important. Perhaps surprisingly, results revealed that all of the items and factors were very important to the respondents. We also invited them to choose the 5 most important aspects of continence care from that list, and the top 5 are listed here. Not surprisingly, access to timely staff help to reach and use the toilet, help to maintain continence, dignity, and a skilled and trained workforce at a facility level. An inductive thematic analysis of the qualitative data revealed 4 major themes that confirmed and validated the quantitative findings, and these were about the importance of person-centred continence care, and these are the sub-themes that related to that. Practical assistance to optimise continence, staff knowledge and education, and adequate resourcing. And so the data from each of these activities was synthesised to design or draft a best practice model of continence care that promotes 10 core principles. And these are around person-centred continence care, enablement through shared decision-making, clinically informed care through an assessment process, care that's informed by the best available evidence, care that protects the residents' dignity, optimises their function, is timely and responsive, inclusive and respectful, safe, provided by appropriately trained and skilled staff, and appropriately resourced continence care. And 5 knowledge translation resources were also designed to support the implementation of the model, and these include a consumer guide, a continence care decision support tool for staff, an organisational audit tool for managers and quality assessors, an education resource, and the evidence statements. A pilot test of a 3-hour online education program for residential aged care staff about the model showed no statistically significant differences in their knowledge scores. There were, however, high ratings of the feasibility, acceptability, appropriateness, and scalability of the model and the education program. And in terms of the findings from the qualitative interviews with residents, they also validated the salience of the concepts that underpin the model. And these concepts are listed here, and the main ones being choice and autonomy and recognition of their values, goals, and preferences, etc. So in conclusion, the best practice model of continence care in residential aged care promotes an evidence-based, safe, clinically informed, person-centred approach to continence care and aims to optimise a resident's functional abilities and respond to their individual needs, choices and dignity. Further research is required to determine its contextual relevance for use in long-term care homes in other countries, and a controlled study is required to explore its impact more broadly on practice and resident outcomes. Again, I'd like to thank my colleagues, my team members here, and also the Continence Foundation for funding us, for our expert advisors and the project advisory group and the ICS. Thank you very much.